is the histological feature of the another important organ. These are the thyroid gland and parathyroid gland, right? As you can see in your neck that it is present just below the all this sound box cartilage, right? And anterior to your trachea. It is in a form of H-shaped structure and being connected the two lobes via a block of H, that is the middle isthmus, right? And you can see so many blood vessels over it, like superior thyroidal vessels, inferior thyroid vessels. So it is one of the well vascularized organ in your body. Again, we know that it is an endocrine, so we have to remember the four C's. So do recall, which we have already learned. We will see them one by one. But you must know that it is responsible for your growth development, even for your nervous development. So sometimes if it is not available or it's not functioning properly, during, you would say, embryonic period, it may lead to congenital hypothyroidism, right? Okay, let's see some features. Okay, this is the slide we have to see in the microscope. There are different sections. In the first, you have seen it in the first year as well, that there are millions of follicles scattered and densely packed, and they've got epithelium, which is simple cuboidal, right? Okay, you can see the associated another slide of the same, but with a little bit higher magnification, and on the very lower corner in the mammary trichome staining, you can observe the simple cuboidal epithelium, which are also known as thyrocytes. Okay, the shape or the size of the cell is dependent upon the TSH, and you should recall from where we get the TSH. Yeah, and it gets signals from
TRH from hyperthyroidism.
yeah, very good. So the size activity depends upon if they are present, there is hypothyroidism or the things like that when they are not functioning. So these simple cuboidal epithelial lining could be simple squamous. Okay? And if they are in the hyperfunctioning state, they could be as tall as columnar. So it means the epithelium can vary. ऐसे ही है जैसे आप किसी टिश्यू से काम ना करवाएं, it becomes flattened. आपके मस्कुलर टिश्यू देखते हो, उसको आप बिल्ड करते हो, they become hypertrophied. तो ऐसे ही if cell is not functioning properly, they could be squamous in shape, right? But if you take a much function like to produce a lot many thyroid hormone, they could be columnar. But in normal or a healthy human, we find the simple cuboidal epithelium. These are few things we should keep in mind. Okay, these are clinical aspects we will discuss one by one. Okay, this is the posterior aspect of the thyroid gland. We are looking posteriorly what two structures? Most anterior, if you see the tube from below upwards, that is the trachea. Behind that is the esophagus, and above that you are observing the pharyngeal musculature. But if you see, there is the thyroid gland on both sides. It means it's complete or lying anteriorly. But what we are supposed to see on its posterior aspect, we have parathyroid glands. They are four in number. The superior parathyroid gland and two inferior. The superior, they are derived from four pharyngeal pouch, right? And the lower one getting from third. So both these pharyngeal pouches are contributing in its embryological development. And this parathyroid hormone is crucial. It's very essential for the proper, you would say, life survival. Because if incidentally a surgeon is going to do thyroidectomy, what he is supposed to do? He has to do it subtotal thyroidectomy. What it means? That he or she has to preserve a portion of thyroid, because we want to keep these parathyroid safe. Why? Because they are supposed to produce parathyroid hormone, that is a major regulator of your calcium. If it is not there, the death may ensue, right? Because if there is no calcium, the technic contraction, especially in your laryngeal and respiratory muscles, and finally, a person may not survive. So very important thing, clinically we can observe. On the sidebar, you can see the histological slide of the parathyroid. At one glance, it appears a purplish tissue. We will discuss why it is, because the cells inside residing, the major cells or principal cells or chief cells, they have got larger size nuclei. That nuclei gets much more stain, and the peripheral thin rim of cytoplasm is rather unseen. So if I ask you to sit closer and your heads I can see, so they give the darker stain. So all this is due to the presence of chief cells. But you can observe intervening bulk of another lighter stained cells. These are called as oxyphil cells. Here, nucleus to cytoplasm ratio is reversed. Nucleus is of small size and cytoplasm is of larger size, right? And well laden with the mitochondria. That's why you can see they are having the intense eosinophilic stain, right? Okay. So the pictures which will come in our way, we will discuss one by one. Okay, a picture has come in front of you related to the thyroid gland. You can see the bulging eyes. This is one of the example of exophalos of the Graves disease. And what Graves disease is? It is an autoimmune disorder of the thyroid gland, and there should be enlarged thyroid gland in the neck region. And you see the patient is having protruded eyeballs and retracted eyelids. So one of the strong reason is that we have got autoantibodies and they deposit extra fat behind the periorbital region, causing that edematous tissue and your eyes get bulged. So always consider such patients whose neck has got enlarged, sometimes this goiter called goiter, and with the protruding eyes. Okay, if a patient comes with the extreme heat intolerance, not in the summer weather, but in the regular environment when there is no such heat, still he or she is complaining of excessive heat, or she or he is very much nervous, thin lean, and due to high metabolic rate. These could be symptoms. This is like if you are in your clinic, a patient enters into your clinic with the fighting attitude, with a very aggressive attitude. So don't give a shut up call to that. He's a patient and he may be a patient of hyperthyroidism. He's having palpitation, excessive sweating, heat intolerance, all these major activities could be going on. So when we examine it, then we let it know that what is the pathological condition behind. Then you can see the other things, that whenever there is iodine deficiency, our belt is also like that, and we can lead to underlying diseases that will influence the thyroid. And other features you can see whenever there is thyroid hypofunctioning as well, right? And in that, in kids or children, the cretinism is the clinical condition. The person could be dwarf, could be looking like obese. Now the cold intolerance would be a feature. With the slow reflexes, with the lack of concentration could be the problem. If you observe, so it means the hyper and hypo, they contradict. But the goiter is seems to be similar. So you have to evaluate whether there is hyperthyroidism or hypothyroidism. Right? In adult, we name it as myxedema. So sometimes that involves so much fuss in a patient that we call it as myxedema madness. And you observe swollen all the body features. There could be slowness in the even responses, and there will be the coarse, rough skin of the patient will be there. And you observe their enlarged thyroid. Okay, we will see some other diagrams. That could be a feature. See how much peripheral edema the patient has got, even on the faces and even with this tummy is also getting so much edematous. So these are the condition of goiter and cretinism. If there is a kid, you have to evaluate, or if there is an adult, you have to work accordingly. You can see the enlarged goiter. That can be so much enlarged. Sometimes people used to cover it, but you have to ask questions, you have to pick the sign symptoms, you have to give the findings, then you get that these are the cases of thyroid abnormalities. Okay. Okay, let's see. Parathyroid has come in our way as we have learned these were superior, inferior. Now these parathyroid hormone, how they keep your blood calcium level to that high level. How? They act on the bone, they stimulate the osteoblast cell that will influence the osteoclast stimulating factor. The osteoclast will come into action and they act on the calcified bony matrix and that takes calcium out in your blood, right? The other way, they act on your kidney. How? They will be doing what? They will order, you would say, distal convoluted tubules to take or absorb more calcium. And the proximal convoluted tubule will not absorb the phosphate. So the third thing that they indirectly influence your gut to absorb more calcium from your diet, right? And well, the kidney also help you to convert the inactive vitamin into active form. So these are the some factors that how we get increased calcium level in our blood with the help of it. These are again showing the anterior aspect of the thyroid, right? And the posterior, which is showing the four yellowish color parathyroid glands. Okay. Now we have to see some other pictures. The feedback, positive feedback and negative feedback mechanism, how your body works or respond to cold and heat mechanism, right? Hypothalamus is there, pituitary, which is anterior pituitary is there. So keep in mind that thyroid releasing hormone is coming through your hypothalamus, right? And it is going to act on your pituitary now, and it has to secrete thyroid stimulating hormone, right? And now it will reach to the target organ, that is the thyroid gland. And what it will do? It will act on this gland to produce more thyroid hormone. And when thyroid hormone is reaching or higher in amount, what it has to do? Your body will be responding it finally by having shivering, by conserving heat, and when enough basal metabolic rate is reached, the negative feedback mechanism will stop or reach the anterior pituitary, and the secretion of TSH and TRH will be stopped. This is the negative loop, right? From one side you get the positive signals. Whenever there is low thyroxine, the signals through the blood, as you know that endocrine, all the things they get is from the blood. Okay. Now this is the tissue showing you the yellowish portion. Lower is the thyroid gland and the buried purple portion is the parathyroid gland. The thyroid gland, let me make it a little bit more enlarged. Okay. The yellowish portion, the thyroid gland is showing multiple follicles lined with the simple cuboidal epithelium. And on its vicinity, on its outer side, you have got parafollicular cells, which are larger in size than that of this follicular cells, right? And what they produce? They produce calcitonin. This calcitonin is the antagonist of parathyroid hormone, right? It has to lower the calcium level, right? So they act accordingly. Now, among the parathyroid, again we see the two types of cell. One we discussed with the darker purplish stained nuclei. These were chief cells. They are 90% of them, right? And they are supposed to produce parathyroid hormone. The other variety is the oxyphil cell. Their size is larger. Their nuclei are smaller. They are present as a form of a clump, and usually they produce a very low amount of parathyroid hormone. Rather, sometimes the function seems to be quiescent, but it is there. But intensely eosinophilic stain because of the increased amount of mitochondria inside. Okay, so what four C's we have to repeat? If we discuss this thyroid or either parathyroid, we have to tell there should be connective tissue capsule on the outside, which is of dense irregular variety, and it has to send septa inside again for the passage of neurovascular bundle. Now we come across the third C, which is well laden, fenestrated or sinusoidal capillaries, well laden, right? Then the arrangement of the cells. So look, in the thyroid, they arrange the shape of a rounded curve. They form a follicle, millions of them. And in parathyroid, they are in the form of anastomosing cord, the chief cells. And what about the oxyphil cells? They are present as a form of a clump, right? Okay, any other picture if we get? This is a view to show you the parathyroid gland individually, how the chief cells appear, how the oxyphil cell appear. And the lower region is supposed to show you that superior and inferior thyroidal arteries are reaching and supplying the respective gland. Again, another picture, schematic representation on the top, the gross appearance, and on the lower region, you see the follicular cells. These follicular cells, the thyroid is one of the endocrine gland that stores maximum amount of its secretion in the center of the cavity, not within the cell. Right? You get it? These are the cell lining. These are the follicle cells, these green one. And the central portion, which you call it as gelatinous colloid, that is glycoprotein, right? So all this thyroglobulin that is being stored in the center to form the jelly-like colloid and gets enough staining. Wait, let's concentrate again. An important thing may be related to your biochemistry. Now these blue lined, these cells are thyroid follicle or called as thyrocytes, right? On this edge you can see the whole follicle and the chunk is taken or a single cell is taken. What happens is that inside the cell there is a factory running. Can you help me recall the organelles inside? Okay, let me mention. Smooth endoplasmic could be there, but we are concerned here with the rough endoplasmic reticulum, the supranuclear Golgi complex, the mitochondria, the lysosome, and even the endocytotic vesicles are there, right? These things are inside present. So what happens? That the thyroglobulin, which is a main content, that is not a hormone. What is going to happen? This is being secreted by the rough endoplasmic reticulum, but its glycosylation occurs in the Golgi complex. Okay, still it is not that so that we can function it properly, we can use it. What happens? That its iodination is required. So if you concentrate this red area, this is the capillary. So from here, near to this basolateral area, you observe sodium oblique iodide symporter. This is called as NIS, N-I-S. So this is present near the basolateral area. So it is carrying things inside this follicle, right? And from the basolateral region, you can also observe the endoplasmic reticulum that is also secreting this thyroglobulin, and it is supposed to go out inside the central cavity, this cavity where colloid is there. And from here we have reached towards the apical side where even microvilli are also present, and in between the cells, apical junctional complexes are apart. But here what we see pendrin 1. This is for the iodide in exchange of chloride transporter. And this iodide has taken out. Now what happens? The iodide should be converted into iodine, right? So we need tyrosine oxidase. So it means that glycoprotein that was not a hormone, rather its content, that is tyrosine residues. They are actually crucial for this making of T3 and T4. So now when the tyrosine residues have come, their oxidation has to be done, and now iodine is being produced. So we get MIT and DIT, monoiodotyrosine and diiodotyrosine, right? And then there is conjugation of them occur, and finally we get T3 and T4, right? Still, they are present jam packed here in this vicinity of the colloid and attached with the glycoprotein. Whenever they are needed, they are released. And let me tell you, the T4 is present in maximum amount, but less active. T3 is in less amount but more active. So this is how they work. This is important that you should know the functioning. So again, if you see the form of a chart, that you see the thyroid follicle is there lined with a simple cuboidal epithelium. In the center, you have got colloid, gelatinous colloid. What is it? That can be Viva question. So you can answer this is thyroglobulin, a glycoprotein. So when TSH is acting on it, it has to then convert its iodide into iodine, and then with the tyrosine residues they are combining, and finally on one side you see diiodotyrosine, on the other side MIT, right? And finally when D and M they combine, they result in the formation of T3. When this DIT molecule they combine with the other DIT molecule, you get T4, right? So when you get these two, they have got greater metabolic activity that is required for your growth, that is required for our nervous system, and all the mechanism running in our body. Again, just to show you or make you recall that never forget the hypothalamus on the top, then the pituitary, and how they are getting signals and reaching towards the target organ, which is right now is the thyroid, right? And they are producing T3 and T4 and causing increased metabolism. The growth development is there, and the catecholamines effect is also there, which we call whenever there is hyperthyroidism. The patient is nervous, aggressive, but in hypothyroidism, there could be a patient obese with a coarse skin, with the cold intolerance. These are the features. They both features is contradicting. Again, a chart to show you the relation of hypothalamus, pituitary, thyroid, and TSH and how they are forming it. Any one chart you learn, then you will make it easy to memorize. Okay, this is again just to show you that low thyroid hormone is causing the pathological condition inside. A person is in need of TSH, that signal is finally reaching towards your thyroid, and the level is increase of the T3 and T4, and the body is working healthy. Then what happens? It gives negative feedback mechanism that don't secrete TSH now. We have enough. Okay. So any other related, again the gross appearance and location. This is the blood supply to show you that how they get it. Okay, these are the symptoms. If somebody asks you what are the symptoms of the hypothyroidism case, having all these features, infertility, other dysfunctional problem, muscular pain, hair loss could be there, goiter, memory problem, depression, sensitivity to cold, weight gain, fatigue. These could be the features. Okay. That was a slide we will see in practical, but this lower purple portion is the parathyroid, right? The above portion, which is showing this all, are the collection of so many millions of thyroid follicles, right? So we can see two slides in one place. So I think this is all for today. Thank you.